Hello, everyone. We are so excited to see you all. We have about 70 people registered for this event, so we know more people will be joining us in the waiting room. My name is Tuesday Dyer. I'm the Executive Director for CFC International. I've had the wonderful opportunity to meet so many of you already, but I see a lot of new families coming into this call, so that's really exciting. There is no doubt that behavior in CFC syndrome is one of the primary subjects and questions we get, how to manage behavior, how to interact, create an environment for your child that is supportive of some of the conditions that they might have in behavior related to CFC syndrome. I'm a mom to a almost 12-year-old with CFC syndrome, so we are certainly familiar with the wide range of behavioral spectrum that we see. I'm going to take a moment to actually introduce our speaker, which is kind of exciting because I've known Rene for a while. I always say Rene is the very first CFC syndrome expert that we ever met, just after Emmett was diagnosed, and he was about 3 months old. So I'm very excited to have Dr. Rene Pierpornt with us tonight. She is a pediatric neuropsychiatrist and assistant professor of pediatrics. She is licensed as a psychologist through the Minnesota Board of Psychology. She works with individuals during infancy through young adulthood. In her clinical work, Dr. Pierpont conducts neuropsychological evaluations and consultations with children with complex medical and neurodevelopmental conditions. Dr. Pierpont's research focuses on neurocognitive and behavioral development in children with genetic syndromes like CFC syndrome and other RASopathies, Noonan syndrome, Costello syndrome. Dr. Pierpont is presently a K-23 scholar funded by the National Institute for Neurological Disorders and Stroke, the NINS Institute. And she is a member of the Center for Neurobehavioral Development at the University of Minnesota, the International Neuropsychological Society, and the American Psychological Association Division 40. She also participates on the Medical Advisory Board for Noonan Syndrome Foundation. And in addition to our research and clinical work, Dr. Pierpont is passionate about partnering with patient communities to develop better resources, guidelines, and avenues of care for children with genetic conditions. I'm just going to provide my own 2 cents here, which is that Dr. Pierpont has been involved with CFC International since she was a child. Her mother, her mother was very, very instrumental in the work that CFC International has done. Dr. Mariella Pierpont was just an amazing hero and contributor to all of the work that we've done in finding the genes of CFC syndrome and creating a pathway for families to understand how to improve the lives of their children. I also want to say Dr. Rene Pierpont has been a recipient of grants for CFC International that has funded research like the natural history study that some of you are familiar with, and behavioral studies within CFC syndrome. So we are very excited to have her here. I am going to ask that everybody stay on mute. If you have a question, please place it in the chat. At the end of Dr. Pierpont's presentation, I will review the questions and make sure that they are answered. Once those questions in chat are answered, you are certainly welcome to raise your hand, but I want to make sure that we get through those questions in chat first because those are the questions that are occurring to you in real time. So thank you, everyone.
All right, let me get my screen shared. Are you seeing it? All right. Good evening, everybody. I am delighted to be here today to have a conversation with you about behavior. Behavior is one of the most wickedly complex challenges that we face in supporting kids and teens with neurodevelopmental differences, and it is overwhelmingly, as Tuesday said, one of the most common concerns among caregivers in the CFC community. As a clinician and a researcher, I've always been drawn to certainty and clear answers. I like knowing things, but the more I've learned about the complexity of CFC, the more I've had to step back and embrace curiosity instead. I imagine many of you as parents or professionals can relate. You might have had a vision for what family life would look like, or how you would parent. But when CFC entered the picture, those plans shifted in some major ways. And my hope is that we can navigate that uncertainty together while still pushing forward for the best possible health, functioning, and well-being for people with CFC and for the people around them. I will share a lot of data today. Some of it's very fresh off the presses, but I can't promise a clear-cut roadmap that will work for every situation. Instead, I'd like to offer two things. First, I will invite you to kind of peer through what I'll call a lens of curiosity as you think about, observe, reflect on your loved one's behaviors. So you might try this, or you might even encourage others in your life to do the same when interacting with your children. And we'll talk more about this in a bit. And then second, after sharing some findings from our research studies, which will be kind of the bulk of the talk today, I will offer some suggestions for tools and resources that may help with challenging behaviors if those tools feel right for your family. Before we jump in further, I want to thank the incredible sponsors who've supported this research, especially CFC International. We're deeply appreciative of the support and the collaboration of this community, as well as sponsors at my institution and at the National Institutes of Health. Okay, let's talk about that lens of curiosity that I mentioned before. When we talk about challenging behaviors, it's worth asking the question, challenging for whom? For whom is this behavior challenging? Often what we label as a behavior challenge is primarily challenging to us as caregivers because it, disrupts our routines or clashes with our expectations. But for the child or the individual, that same behavior might be their most logical response to an overwhelming situation, or an unmet need, or even a developmental stage that they're navigating. For them, a meltdown in the grocery store might not be challenging at all. It might be their form of communication. Now, you might be thinking some behaviors are genuinely unsafe and need intervention, and that's valid. But here's the crucial point. Understanding a behavior and addressing a behavior aren't kind of opposites. And so thinking about and being curious about what's driving unsafe behavior, what need it's meeting, what fear it's expressing, is what allows us to interrupt it effectively and replace it with something better. So then when we recognize our own discomfort with a behavior, it sort of fundamentally shifts how we respond. And instead of asking, how do I stop this? We can ask, what is this child experiencing? And is it safe? So we can hold both truths at once. This behavior needs to change, and this person deserves to be understood. And so with this lens in mind, then I'll return to the concept of staying curious. I want to share what we learned from our first initial study on behavior in CFC. And this was published about 9 years ago. This research included data from 34 families with CFC, and it was shaped by the expertise of Dr. Melinda Wolford, a brilliant school psychologist and also a valued member of the CFC community, who many of you will probably know. Back then, when we were doing this study, we didn't have Zoom, and so it was much harder to reach as many people remotely as it is now. But this small study laid important groundwork for more focused research later on. Dr. Wolford and I worked together, along with families like you, to conduct a survey to explore common behavioral concerns in CFC and determine how they might connect to medical aspects of CFC. Our surveys asked about sensory modulation, about communication skills, and we also asked parents to share about their experiences of parenting, including whether and how they had experienced stress around parenting. And I'll start off by sharing what we found in terms of the landscape of the behaviors. So we used a quantitative approach with a broad questionnaire that captured kind of many aspects of emotional and behavioral functioning. And what emerged suggested that compared to the general population, individuals with CFC showed notably higher rates of both internalizing behaviors, things like anxiety, depression, and withdrawal symptoms directed inward, and externalizing behaviors, aggression, irritability, and emotional outbursts expressed outward. Parents also reported challenges with attention, with social development, and with unusual behavior patterns associated with autism spectrum disorder, including self-injury. The percentages I'm showing you here represent the proportion of individuals with CFC rated as having what we would call clinically significant behaviors in each category. And the basic summary here is that depending on the category, between 1 in 5, up to half of individuals in this study showed significant emotional or behavioral challenges that fit under these categories. And these are just what we would consider like clinically significant. Many participants might show kind of milder patterns of behavior that wouldn't necessarily indicate likely presence of a diagnosis. And what stood out to me was that when we looked into the details, specifically when we sought to understand more about sensory modulation in CFC, we found some really interesting connections. So sensory modulation is kind of like turning a dial to balance how we take in and process information. It's how our brain organizes sensations to help us learn and to help us meet our needs. And when kids struggle with this, it can lead to anxiety, aggression, or behaviors aimed at kind of escaping that sensory overload. This chart shows the proportion of people with CFC who have typical sensory processing. That's the white portions of each bar. Those that have moderate sensory differences needing some accommodation, that's the light gray portions of the bar. And then the dark gray represents the proportion of patients that have more significant differences that deeply shape someone's experience. So each bar represents a different aspect of sensory processing. And it should become quickly apparent that most of the participants in the study were showing atypical sensory processing in at least one, but more often many areas. When we analyzed the data, we saw that sensory processing differences were strongly tied to the behaviors that parents were noticing. So understanding how individuals with CFC process sensory input, whether they're kind of seeking more input or avoiding it, or struggling with kind of filtering out unnecessary or distressing sensory input, helps us see many challenging behaviors as adaptive responses to their environment. We also explored factors in participants' medical history that might contribute to these behaviors. Things like seizures, cardiac disease, feeding issues, and perinatal or obstetric complications. And those perinatal complications, like premature birth, they were the only factor that had a clearly meaningful link to behavior concerns among the medical history that we were looking at. One final finding I'd like to share about this initial study was related to how study participants, in this case caregivers, rated their own stress in parenting. This graph may not surprise any of you, but it really illustrates kind of to the broader community how behavior problems, things like anxiety and mood difficulties and oppositional behaviors, and caregiver stress are strongly correlated in CFC families. So caregivers who reported more behavior problems in the individuals with CFC also described higher parenting stress. So to summarize the key points so far, in this first study we learned that behavior concerns are wide-ranging in CFC. They are linked to early perinatal history and complications at birth, and they're also linked to sensory processing differences. Behavior problems are also associated with increased stress in family members. So after we completed this first study, one of my research assistants at the time, her name was Sakshi Daswani, she helped me to develop a colorful handout that discusses the findings of that study in more detail. And you can still find this pamphlet on the CFC website, and it's something that you can share with family, teachers, therapists, or anyone involved in your loved one's life who might be interested. One thing this initial study highlighted for me was that many of the behaviors common in CFC aren't fully captured by assessment tools that are designed for the general population. And that matters because it means we need to listen carefully to what parents and caregivers are observing and to consider the unique neurobiological landscape of CFC. So the next study we did had a few goals aimed at expanding on what we learned from this first one. And so why complete another study? So first, instead of looking at emotions and behavior really broadly like we did in the first study, we wanted to focus on a set of behaviors that are especially stressful for caregivers, and I'll tell you more about that in a second. Second, with a really enlarged community and many more families having genetic testing now, we also wanted to explore how different CFC genes might influence behavior differently. Third, we wanted to delve deeper into some of the neurological variables that could influence behavior. And then lastly, this part's really important, we wanted to understand the functions behind the behaviors to really know what types of motivations or influences drive the behaviors, because that's where we can start to tease out which types of therapeutic or caregiver responses might be most helpful to reduce stress in family life and prevent harm. To do this, we brought together a team of clinicians and students who are very interested in behavior in young people with developmental disabilities. On the left are Dr. Adele Dimian and Dr. Becky Hudock. They specialize in offering assessment and therapeutic services here at the University of Minnesota for individuals with intellectual disabilities and those on the autism spectrum. On the right are Dante Rogers and Josue Colazo Lopez, two students who assisted with data collection and with analyses on these projects. With help from CFC International, we set out a goal to study at least 50 individuals with CFC syndrome, obtaining very detailed information about challenging behaviors in particular. We recruited volunteers at the 2022 CFC International meeting and through the advocacy group listservs. Participants were caregivers of children and adults with CFC who were willing to spend some time with us providing detailed information about their child's medical history, their behaviors, and their utilization of services. I couldn't resist including a snapshot from the CFC International family meeting. Some of you might remember the awesome photo booth with dress-up items that was at the banquet. So here's our study team taking a break after a day of research and enjoying some time with everyone at the meeting. Let's dive into the results of the second research study, which has recently been published in a scientific article. And we've also put together a family newsletter that will be circulating within your community. The final participant group in this study included 61 families from 10 different countries. CFC International truly does have an international reach. Individuals with CFC reported on in the study ranged in age from 2 years to 40 years of age. The majority of participants had variants affecting the BRAF gene, but about 40% had variants in MAP2K1 or MAP2K2. In this study, we learned from caregivers not just what the behaviors looked like, but also we asked a lot about how often they happened and critically, how much they disrupted daily life. And we focused on 3 distinct patterns of behavior. First, we looked really deeply into self-injurious behaviors. These are repetitive actions like biting, hitting, pinching, hair pulling, or teeth grinding that harm the person's own body in the same way repeatedly. Second, we looked at aggressive and destructive behaviors aimed outward, so deliberate acts like hitting, pushing, biting, or scratching others, or damaging objects around them. Stereotyped behaviors are repetitive or unusual actions that might seem odd to others, but don't really cause harm. Things like spinning, pacing, yelling, grimacing, or clapping hands fall under that category. And what we found was that about 95% of parents in the study noticed their kids doing at least one of these behaviors, though it's also, as I said, important to take into account how often it happens. Our next question was, which of these behaviors truly count as challenging, the kind of behaviors that seriously disrupt daily life? To figure this out, we used a framework developed by researchers who identified 3 key criteria. First, a self-injurious behavior or an aggressive behavior was considered challenging if it was rated as severe, no matter how often it happened. Second, if it was rated as moderate and happened at least weekly. And third, even mild behaviors could be considered challenging if they occurred every single day. For stereotyped behavior, because they don't cause damage to someone's own body or someone else, we only considered those behaviors as challenging if they happened at least once per hour. And the logic here is important. So repetition alone doesn't make a behavior problematic. A behavior only becomes truly challenging when it's happening so frequently that it's consuming a person's time, interfering with school or with socializing, or with the basic rhythms of daily life. This framework gave us our barometer and showed us how many families in our study truly could be considered in need of behavioral support for challenging behaviors. And the answer was pretty striking. 77% of our participants met the criteria for challenging behaviors. So to every family watching, if behavior is at the heart of your concerns about your child's well-being, if it keeps you up at night, maybe literally, we'll talk about how sleep and behavior go together in a minute, or if it leaves you searching for answers, you are not alone. One question that arises here is, why are these behaviors so much more common in CFC compared to the general population, and even compared to children with other intellectual and developmental disabilities? In thinking about this, I looked into some research that shows that people with genetic conditions that affect sensory and physical health are at much higher risk for these behaviors than those who have developmental disabilities without a known genetic cause. I thought that was really striking. And this led to the next question, which is, I have a lot of questions, which is whether the behaviors are linked more to some CFC genes than to others. Okay, this is a really fun, interesting way of depicting data. It's a graph that might not be super familiar, so I'll kind of explain it a little bit. This graph identifies both the frequency and the severity of different behaviors that were listed on one of our self-injurious behavior surveys. Here, the bubble colors represent different CFC genes. So blue for BRAF, orange for MAP2K1, and green for MAP2K2. Now, the height of the bubble on the graph shows the percentage of people with a variant in that gene who exhibit the behavior. So ones that are higher up indicate a higher percent of participants showed that behavior. And the size of the bubble represents how severe the caregiver rated it. So larger and higher up bubbles mean more participants displayed the behavior and rated it as more severe. So across most of these different items, which represent behaviors like hitting, biting, pulling hair, scratching, or rubbing oneself, most of them were more frequent and more severe in participants with BRAF variants and MAP2K1 variants as compared to MAP2K2. For some behaviors, none of the MAP2K2 participants showed them at all. So this pattern kind of aligns with some of our past studies, finding that intellectual disability and also epilepsy severity tends to be milder in people with MAP2K2 variants. Speaking of epilepsy, this transitions well to the next section, where I'd like to talk about some of the different neurological variables that were associated with behavior in our study participants. In this next section, I'll kind of sprinkle in some quotes from caregivers, and these quotes were in response to a question we had about what was their biggest concern with their child's development or behavior. And I hope these quotes will kind of help bring each variable or each topic that I'm talking about to life. So the graph here shows average scores across several different measures of repetitive or challenging behavior, and they're grouped based on the presence or severity of different neurological concerns. And I'll unpack these one at a time. The first one I want to talk about is epilepsy. Surprisingly to me, this turned out to be one of the less dramatic patterns. This kind of graph that I've circled on the left shows that participants with epilepsy, which are on the left bar, displayed just slightly more self-injurious and stereotyped behaviors than those without epilepsy. But the difference wasn't huge. And this parallels our previous studies, which have noted very clear correlations between epilepsy and cognitive or adaptive skill development, but have not found a really striking relationship between epilepsy and kind of emotional and behavioral concerns. That doesn't mean there's no relationship. It just wasn't really strong or striking in this study. Whoops. Yes. Okay. So for some individuals, there might have been a bit clearer connection. So some caregivers certainly saw links between epilepsy, particularly epilepsy medications and behavior, which is a commonly described scenario that I've discussed with many families over the years, or perhaps between epilepsy and stress, where the stress triggers seizures for some children. And I'm using the term children, but I often I speak about children a lot being in a pediatrics department, but I really mean children and adults because there were adults in this study. A second variable that we looked at was sleep. So what we found here is that participants who had clinically significant sleep disturbance, which is the left bar, exhibited quite a bit higher levels of all challenging and repetitive behaviors, nearly double in some areas, as compared to the participants who didn't have clinically significant sleep problems, didn't have really high levels of sleep disturbance. And that's illustrated by this quote from one parent saying, without medications, my child can't go to sleep on his own. He's very fitful and restless, scratching his arms and shoulders and moaning, moving his legs a lot. And so I really think that this connection between sleep and behavior needs to be further explored, and really sleep patterns in general is an area of need. Another set of neurological variables we looked at, which I'm going to talk about together here, were pain and sensory responsiveness. So we looked at something called pain interference, which is just the extent to which parents perceive pain as interfering with their child's ability to engage in social activities and daily life activities. And we found that increased pain interference, individuals with greater pain interference in daily life, showed higher levels of challenging behavior. And we found that participants similarly with higher degree of sensory sensitivities and responsiveness to sensory input who get really overwhelmed by sensory information, they also showed higher levels of challenging and repetitive behaviors compared to those with typical sensory responsiveness and lower or no pain interference. Here's some illustrative quotes about these connections. So one parent said that their child's recent behavioral issues that included aggression and self-induced vomiting were a result of GI pain or stomach pain. And another parent described the stress that comes along with sudden changes in sensory input, sudden noises or changes in volume or movements in his environment is causing a lot of stress and behaviors. And lastly, we asked about participants functioning in terms of their independence in daily life skills. We sometimes call this adaptive functioning. And participants with the highest levels of independence in daily life activities, that's the farthest left within that the highlighted section here, they showed by far the lowest frequency of challenging behaviors, whereas patients with fewer independent communication skills, social skills, and daily living skills who depended more on support in all of those areas, they tended to have more challenging behaviors on the survey. Here we have a few quotes from parents describing how communication and motor limitations really contributed to frustration and behavioral issues for their child. All right, so based on all of this information, it's clear that genetic and neurological risk factors are associated with CFC in some cases, like seizures, severely delayed development, sleep disturbances, and pain. All of those things are contributors to the overall behavioral presentation, and they help to explain why the behaviors are so common in CFC particularly. Next, we wanted to look at whether behaviors were seen at all stages of development or just at certain ages. So in this graph, we divided participants into 4 different age groups to see how often caregivers were observing challenging behaviors. And this graph reflects data on all types of repetitive behaviors, including things like self-injury and aggression. And across different questionnaires that we looked at, we noticed the same consistent pattern, that the highest frequency and severity of these behaviors was occurring among the participants who were adolescents, especially those ages 12 to 17. And that was closely followed by participants in middle childhood. So while young children and adults did show behavioral concerns for sure, they were generally less pronounced than among participants in the teen years. And this pattern, as I said, was pretty steady across several different measures of behavior. I do want to note one thing here. So this study didn't track participants' behavior changes over time as they got older. So we can't really say whether certain behaviors became more difficult across developmental stages. But what we can say is that giving families extra support during adolescence seems really important. One parent shared that puberty brought some big challenges for her, that more aggression toward others and changes in her child's mood seemed to be connected with puberty. Before we dive into tools and resources, I want to discuss one more key finding from these data. This finding comes from a questionnaire where parents connected challenging behaviors to specific motivations or functions. And I'll go through these from the most common to the least common, although all of these functions were observed among some participants. So the most common, the most frequently indicated function that contributed to behavior is something that we call escape. And this is where the behavior is a way to avoid doing something unpleasant. And this was the most common function that was associated with both self-injurious behaviors and aggressive behaviors in the study. So here are a couple of examples of escape. So one participant describing her child wanting to escape or avoid interacting with unfamiliar people. And another parent described some combativeness with things that the child didn't want to do, including teeth brushing, going to bed, and medical appointments. The next most common function was about physical discomfort. So this is related to both sensory processing and pain, which we've already talked about, but this is when a behavior is kind of related to physical distress. So here are some examples. One participant was described as having a hard time with showering and screaming during showering, while another one was described as having a lot of aggression when experiencing pain. So really similar to some of the things that we talked about before. These seem to be real significant drivers of behavior in our kiddos with CFC. Another trigger for some behaviors was simply wanting tangible items, like acting out to get something that they want or that they like, or to try to avoid having a preferred item taken away. And so an example of a tangible thing is getting very frustrated when the TV or the tablet is taken away. The fourth most common function of behaviors was attention. So this is when someone behaves to get attention from others, just like it sounds like a parent saying, one of our parents said, my child needs constant attention. And if you're not paying attention to her, even for a second, you get these acting out behaviors. And another participant was described to intentionally spill her formula when aggravated or wanting that immediate attention. The least common function for behaviors, and this was still seen among the participants in the study, but not as often as some of the other functions. The least common function for behavior was a non-social function. So this is where a behavior happens more automatically when the person is alone, and self-stimulation is a good example of that. And these non-social behaviors, like picking skin in a room by oneself while alone, or self-stimulating behaviors that happen whether or not anyone else is there. These non-social behaviors tend to be a bit harder to manage because they don't often respond as easily to some of our modalities of therapy that are really socially driven. But sometimes providing replacement behaviors can be effective for behaviors that arise from non-social functions. So that was a lot to unpack, and I want to just summarize for a second here. So we saw that self-injurious behaviors and aggressive behaviors across participants with CFC syndrome most often stemmed from desires to escape a situation or avoid a situation, or to ease physical or sensory discomfort or distress. I do want to highlight that for many people, it's not always just one function driving all of their behavior. It's often a mix of different triggers. So for example, one parent shared that their child becomes aggressive or verbally appropriate in a whole variety of situations when dealing with sensory challenges, when feeling tired, when being corrected or not getting their way, And for some children, it can really vary based on the context. What is the strongest driver or function of that behavior? So sometimes behavior can have multiple functions, but I feel like it's fairly illuminating to identify some of the most common and could be helpful in thinking about therapeutic strategies. We've covered a lot of ground today so far. We've learned that about 3 out of 4 children with CFC engage in self-injurious, aggressive, destructive, or repetitive behaviors to an extent that some type of intervention is likely to be helpful. We've learned that the most frequent and severe behaviors are typically seen in patients with BRAF or MAP2K1 variants, but they definitely occur with all subtypes of CFC. We learned that they occur most frequently and severely among participants who are in their teenage years. And we've learned that these behaviors are linked to a pretty broad variety of neurological factors that includes sleep, how much sleep a child's getting, how healthy that sleep is, to what extent pain is a part of their life, their overall development, and especially their tendency towards sensory sensitivities and responsiveness. And we've learned that the functions that drive these behaviors are very individualized, but that getting out of certain situations that they don't like or avoiding physical discomfort or sensory overload are the most common functions across individuals with CFC. I always like to spend some time at the end of my presentations sharing some practical tips or toolkits, things that we can use to improve quality of life and address behaviors, assuming they're the right fit for us. Some of the tools that I will cover are specifically tailored to the CFC community based on the work that I just shared, while others are more universal strategies to support mental health and well-being for all children. Let's first talk about therapeutic interventions. These are structured approaches like behavioral therapy. 2 subtypes of behavioral therapy you might have heard of includes ABA therapy and ESDM, which are therapies common for individuals on the autism spectrum. Other types that could be helpful for the types of behaviors that we talked about in this presentation today include parent-child interaction therapy or telehealth consultations with experts who have experience with behavior in individuals with intellectual and developmental disabilities. So these types of approaches can be beneficial for working on specific skills like toileting or communication, for developing coping skills or replacement behaviors for ones that are harming a child or harming others. And they can be provided intensively in something like a day treatment program. They can be provided in spurts, so just to work on specific skills or consult about a specific concern. Or they can be used sort of gradually over time to shape or guide behaviors to be more adaptive. One tricky situation that can arise is that to get access to some of these therapeutic interventions, most insurance companies require an assessment or a diagnosis that demonstrates a therapeutic need. So in those cases, comprehensive developmental or neuropsychological assessments may be needed. One thing that often happens with CFC is something we call diagnostic overshadowing. And this happens when a rare disease is so prominent that mental health problems can get overlooked. It happens when doctors sort of blame everything on the rare disease instead of recognizing symptoms of depression, anxiety, or other conditions that also need treatment. This can be challenging because mental health services usually require a psychiatric diagnosis to access care, so patients can miss out on help that they need. In those cases, diagnostic assessments can identify these more subtle or overlooked conditions and connect patients with the services that could improve their lives potentially. In some cases, in some situations, medications can be helpful with managing mood and behavior. So these are data from our earlier 2016 study, the one I talked about first. We found that 1 in 4 patients with CFC had taken medication to address behavioral needs. We don't know necessarily a lot of detail about those experiences taking the medication and which ones were helpful, but most typically the ones that were taken were stimulant medications for attention, or antidepressants or antipsychotics to manage anxiety, mood, or behavior. And I would recommend developmental behavioral pediatricians and psychiatrists who are regularly prescribing medications for developmental and behavioral concerns. Anecdotally, I've heard stories from a number of families who've experienced considerable benefits when they found the right medication, but I do think we need some more research to compile that information on which treatments are associated with the best responses. Beyond these more formalized interventions, there are a variety of tips and tricks you can consider. One, I'd like to kind of get back to that idea of approaching things through that lens of curiosity and asking why your loved one is showing this behavior. And you as caregivers, parents, don't have to figure that out alone. Professionals like psychologists, behavior specialists can help by doing a functional behavior assessment. This is something that can be done at school or in a clinic or in your home. It can be done using measures like the ones that we used in this study to identify the functions of key behaviors that we were interested in. And the other type of professional that might be great to have on your team is an occupational therapist. They can really be a valuable resource. They tend to be great at connecting sensory processing with behavior and coming up with useful solutions. Again, as I said at the beginning, curiosity can be a great tool if you feel like people often misunderstand your child's behavior. Let's take the example of chewing or biting. This can happen for several reasons. So let's say we identify that the child is chewing either on their own body or biting others, and this could be it could be a desire for attention. So if attention is the main function of the biting, to reduce biting, we would suggest focusing on the child who was bitten rather than the one who bit. It could be that this behavior is a sign that the child needs space, and if the biter needs space, giving them some room might help. Biting can be a signal of hunger. It could be a signal of a sensory need. So offering food or chewable objects like plastic jewelry, that can be another way to redirect the behavior. If this behavior was socially driven, you might also use books or tools appropriate to their cognitive level to reduce the biting behavior. So that's just one example about thinking through with curiosity what potential functions might be and having that drive what the next step might look like. In terms of addressing sensory needs, a few ideas here. Many of you have been are kind of world experts on how to support sensory needs, but certainly limiting unfamiliar or excessive sensory input can be really helpful. Noise canceling earmuffs, sunglasses, having sensory breaks so that the child is not as constantly feeling as barraged with information and confusing signals throughout the day, enabling portions of the day to have breaks from a lot of sensory input. Introducing new sensory experiences, new textures, new fabrics, I'm trying to think of the word, in a gradual or progressive manner could be helpful. And then one really key behavioral principle is thinking about how we reinforce adaptive or active coping strategies. So if the child is able to seek out support from others, engage in a safer activity, a calming activity, or solve a problem, really providing a lot of reinforcement and support around those replacement behaviors or those coping behaviors that allow them to get their sensory needs met without harm to themselves or others. I put in a couple of books that have been recommended for identifying activities to engage children with sensory processing disorder and understand them. There are many different books, but I just wanted to put that out there as there are many resources on ideas about engaging kids with sensory processing and sensory modulation difficulties in activities. Educational accommodations and advocacy are really important. Developing that individualized education plan with a behavior intervention plan if some of those challenging behaviors are happening at school is a critical tool for those in the U.S. Public school system. Accessing all available speech and language supports is also critical, including assistive communication devices that can help with communication, reduce frustration and anxiety. And then there are organizations like the PACER Center, which is an important agency helping families with educational advocacy when facing challenges, advocating for their child's needs at school. Finally, I want to highlight the importance of advocacy and awareness in supporting people with CFC. This is a time when we're seeing a lot of misinformation in the media regarding the causes of neurodevelopmental disorders, and it's really refreshing to see hopeful stories that support truth and knowledge. And so I put this in here because we have a lovely article from the local paper in Fredericksburg, Virginia that just came out a week or two ago, highlighting the journey of Lacey Milner and her family, who received the diagnosis of CFC later in life, and their experiences finding connection and new treatment approaches. And this type of effort to get the word out and provide education is can really help with public support and knowledge and acceptance of people with disabilities, especially disabilities that affect behavior. I'll close today by reminding us that despite the growing research on CFC, there are still significant limitations in our current knowledge. And I just want to make some reflections on some areas that are relatively unexplored and in need of further study. You all probably feel the same way, that additional research in any of these areas that I've listed could be helpful in treatment of epilepsy, sleep disturbance, pain, communication needs, and treatment modalities such as therapies, medications, parenting, and telehealth interventions. They all have huge potential based on the links that we found between neurologic challenges and behavior to be profoundly impactful in addressing behavior issues in this disease. So behavior is really a symptom, not kind of an underlying trait. And if we can affect change in any of these areas, I hope we can improve quality of life for families. So I'd like to acknowledge the incredible team that worked with me on the research, express my appreciation for all of for the advocacy group for CFCR International for their help with recruitment and the research participants who contributed to this. I hope that our families will feel that this research has helped to kind of center their voice and their perspective as behavior is an important need in this community and as we move toward more clinical research to improve behavioral health. So I'm happy to take questions and I'm going to stop sharing.
Thank you so much, Rene. This was so fascinating to hear. We had a few questions that have already popped up in the chat, and I'm happy to just read those to you. I do want to let everybody know, I reviewed the first 4 questions, and I think they're pretty universal. I think they're also important for the overall purposes of this presentation for people in the recording to be able to hear the response to these questions too. So I will cut off the recording after these first 4 questions. The first one is, at what age did some of the self-injurious behavior start, and does it develop over time?
That is a really great question that we don't know the answer from this study. So we didn't ask the question of what age did your child first start showing this behavior. All of the information that I presented was about the behaviors that the participant was engaging in at the time of the study. So we know that there were some young people at toddler age who were in the study and they were showing some of those behaviors, but they weren't showing them as frequently or severely as the ones who were in middle childhood or adolescence at the time of the study.
Thank you. The next question is, have these studies looked at regression in behaviors and or learning as the child or adult gets older?
Again, so one of the challenges with a lot of studies, but what we really need to overcome in the CFC and rispathies community is that most of our studies are just single time point studies. And what we need to answer a lot of these questions that you're asking is a longitudinal study where we follow the patients for 5 years, 10 years, and gather information year after year. And that typically requires like bigger funding sources like the NIH to follow participants over time. So that's really needed. Anecdotally, I will say I've read all of the comments from participants in the study, and many parents did describe what you're talking about, describe regression in behavior. For example, some of those quotes that I put up there described this increase in aggression at puberty it was something that was seen. Now, I don't know how many participants had that because we didn't specifically ask everyone, did you see that in puberty who was past puberty, but that's something that we could ask in the future to learn more about sort of changes over time. The other thing I've seen, having seen a lot of comments from families about their experience of epilepsy, is that there are certainly many families who've experienced cognitive and developmental regressions in concert with the development or worsening of seizures. So that is something that absolutely happens in this group of young people.
Thank you. And you actually kind of answered the next question, which was variables like hormonal issues, puberty, communication issues, other than neurological variables that might have been factored into the study. You did address puberty. I'm wondering about communication specifically, being nonverbal versus verbal.
Yes. So we did not look as specifically at communication in the second study I talked about, but I didn't talk about this, but we did look at it in the first study. And that was a smaller study. It was 34 people with CFC. And those were just children and adolescents. That was up to age 18 in that first study. What we found I was somewhat surprised. So we did a measure that asked about functional communication, which includes kind of different degrees of ability to express yourself verbally, but also kind of includes just the ability to present messages to others. So many individuals who are nonverbal have really developed abilities to communicate nonverbally, and some do not. And what we found was we did not find, surprisingly, a strong correlation between functional communication abilities and behavior. And that surprised me a little bit because I felt like a lot of the behaviors seemed to be about difficulty communicating. But what we did find a correlation was between the parenting experience and parenting stress and the communication levels of the individuals with CFC. So parents whose children had more limited functional communication abilities really experience excessive stress in parenting, and that makes so much sense to me that it can be so distressing not to know what it is that your child is trying to communicate. And so it absolutely, even if it didn't correlate closely with the specific set of behaviors that we looked at in that study, it's certainly correlated with that experience of parenting a child with CFC syndrome.
Thank you. I'm actually going to stop recording now for the remainder of our questions.